This is Dr. Ron Alterman, and I am narrating this summary of the chapter I wrote with my colleague, Dr. Aguirre Padilla, on complication avoidance in deep brain stimulation surgery. DBS is a highly effective therapy for patients with specific diagnoses and symptoms. These are discussed in detail in other chapters of this book. As the majority of DBS procedures are intended to improve a patient's quality of life, it is essential that the surgery be performed with the lowest possible complication rate so that the patient may enjoy the long-term benefits of the therapy. This presentation describes the senior author's approach to performing DBS with minimal complications, an approach that has evolved over 25 years and more than 1,500 DBS implants. We typically categorize complications related to these surgeries into three categories. One are procedure-related complications. These include intracerebral hemorrhage or stroke, postoperative confusion, and poor lead placement. Then there are hardware-related complications, which include infection, wire breakage, failure of the implantable pulse generator, and bowstringing related to the extension cables. And finally, stimulation-related complications. These are typically target-specific, and they usually occur due to poor lead placement. We separate out poor response to stimulation because that can result from many of the issues that we're going to discuss, ranging throughout the procedure, from selecting the appropriate patients to poor lead placement to poor programming of the device. We begin with the preoperative evaluation. The critical first step to successful DBS surgery is selecting appropriate candidates. And in our opinion, this is best accomplished by a multidisciplinary team, whether you're just treating a patient with a movement disorder, a pain disorder, or a psychiatric disorder. Neurology and psychiatric colleagues provide invaluable assistance to the neurosurgeon, ensuring that operative candidates are properly diagnosed and are appropriate candidates for surgical intervention. They also provide support, programming the implanted devices and managing the underlying disorder during the postoperative period. In my experience, this is especially important when treating children with severe generalized dystonia and emotionally fragile patients with obsessive compulsive disorder or even Tourette's syndrome. Neurocognitive assessments are essential for Parkinson's patients and certain essential tremor patients, given the risks of postoperative confusion and or cognitive decline in patients already suffering with early dementia. Aspirin should be withheld for 7 to 14 days before the surgery to minimize the risk of hemorrhage. Patients who are taking oral anticoagulants may be transitioned to low molecular weight heparin injections 7 days prior to the surgery, and the injections can be discontinued the day before surgery, and both the prothrombin and partial thromboplastin times should be checked on the morning of the procedure. The anticoagulation therapy may then be resumed 1 week after surgery. Anesthetic considerations. The anesthesiologist plays a critical role in the performance of DBS surgery, particularly when the patient is awake or consciously sedated and a stereotactic head frame is being employed. For awake patients, the anesthesiologist or the nurse anesthetist can assist in keeping the patient comfortable and calm during the procedure. When conscious sedation is employed, a skilled anesthetist can keep the patient sedated during unsettling parts of the procedure, such as drilling the burr hole, yet have the patient awake enough to examine during test stimulation. It is important to apply the head frame so that the anesthesiologist may access the airway easily if necessary, and for the anesthesiologist to be comfortable with the use of laryngeal masks, which can be easily inserted even in positions that make full intubation difficult. Hypertension increases the risk of intracerebral hemorrhage, and withholding carbidopa-levodopa can result in rebound hypertension. Consequently, strict blood pressure control is essential to perform this operation safely. We recommend that systolic pressures be maintained less than 140 millimeters of mercury throughout the procedure. Labetalol, hydralazine, and nicardipine are excellent antihypertensive medications for use during deep brain stimulation surgery. Dexmedetomidine or propofol may also be used, but may cause sedation and impact neurophysiological recordings if they are being employed. General anesthetics also lower blood pressure, and their use has been associated with fewer hemorrhagic complications, but at the cost of losing the valuable feedback of the neurological examination. In addition to blood pressure, the pulse, electrocardiogram, and blood oxygenation should all be monitored. Oxygen should be administered via a nasal cannula that is equipped to monitor and title CO2. Meticulous stereotactic technique results in accurate targeting, reducing the risk of poor positioning of DBS leads and suboptimal results. For frame fitting, make sure that there is no prior neurosurgery. If there is, be extra careful with the pin placement, avoiding bone flaps and shunt tubing. The patient should be positioned as comfortably as possible. The head should be elevated no more than 30 degrees to minimize the risk of venous air embolism. Sequential compression devices are applied to the legs to prevent the development of deep venous thrombosis, and a urinary catheter may be inserted for patient comfort. Antibiotics are administered intravenously prior to incision, and standard preparation and draping of the scalp are performed. Clipping all of the patient's hair versus a minimal clipping is at the surgeon's and the patient's discretion. There is no difference in infection rates noted. Here we see our typical operating room setup. On the left, we see an older picture taken when I employed C-arm fluoroscopy in the operating room. The stereotactic head frame has been applied so that the anesthesiologist can gain access to the airway if necessary. And the patient is positioned with his head elevated approximately 30 degrees for his comfort and to minimize the risk of venous air embolism. On the right, we see our current setup using the intraoperative CT scan. Again, the patient's head is elevated 30 degrees. The neurophysiologist is positioned to the left, and a very comfortable and relaxed anesthesiologist is positioned to the right. Trajectory planning. The senior author plans deep brain stimulation surgeries on F-stir and contrast-enhanced 3D T1 weighted, i.e. MP-RAGE MRI. These imaging studies are obtained on the morning of surgery after the frame has been applied. The target is planned on the F-stir, as this demonstrates the deep brain nuclei quite well, while the trajectory is planned on the MP-RAGE. The trajectory is planned to enter the brain anterior to the coronal suture via the crown of a gyrus, thereby avoiding the cortical veins. The trajectory must also avoid the head of the caudate, injury to which can affect cognition, and the lateral ventricles, as the branches of the internal cerebral vein run along its lateral walls. A curvilinear frontal incision may reduce the risk of infection. The burr hole is centered on the planned trajectory, and the raw bony margins are waxed liberally to prevent venous air embolism. The smallest possible opening of the dura is used to reduce CSF losses and brain shift. A sharp corticectomy eases entry of the blunt-tipped surgical cannula into the subcortical white matter with minimal downward displacement of the brain. Microelectrode recording may be used to confirm proper targeting at the surgeon's discretion. However, if one employs MER, we recommend performing only one trajectory at a time and only enough trajectories to confirm proper targeting in order to minimize injury to the brain. Test stimulation via the implanted lead permits the assessment of both therapeutic and adverse stimulation effects, the latter of which can be addressed by adjusting lead position. While newer segmented leads have been shown to widen the therapeutic window and enhance flexibility and refinement of device programming, they are an inadequate substitute for precise lead placement. Postoperative imaging is essential to confirm proper lead placement and to rule out hemorrhage. The senior author prefers to accomplish this with low SAR MRI, which can be performed safely using modern leads. On the left, one sees a T1 weighted MP-RAGE image demonstrating well-positioned bilateral GPI leads. On the right is a low SAR F-stir image demonstrating bilateral STN leads. During the second stage operation, the extension cable should be tunneled deep to the superficial cervical fascia in order to minimize the risk of bowstringing, which can occur with more superficial placement of the extension cable. As with shunt procedures, plunging below the clavicle with the passer can result in pneumothorax or injury to the brachial vessels and/or the brachial plexus. The connections should be cleaned of all blood and dried in order to provide an optimal watertight connection. We prefer to encircle the excess lead wire around the burr hole cover and place the connection between the lead wire and the extension high on the head, just posterior and lateral to the cranial incision, much like a shunt valve placement. This provides considerable strain release, preventing fracture of the lead wire. Some surgeons drill a groove in the skull into which they place the connection between the lead and extension. We have not found this to be necessary. All incisions should be irrigated with copious amounts of saline and closed meticulously to promote efficient healing. The authors do not recommend the use of vancomycin powder within the incisions or a course of postoperative antibiotics, though others employ these measures routinely. Key concepts. Because deep brain stimulation is an elective, quality of life improving intervention, in most instances, it is critical to do all that one can to minimize surgical risk. The most important complications of DBS surgery are intracerebral hemorrhage, infection, and hardware-related complications. Careful attention to patient selection and preparation, surgical planning, and execution are necessary to minimize risk and achieve optimal outcomes.